Hello guys, welcome back. This is Dr Ranjith, your pathology educator at Unacademy. So today we are in one more case series for postgraduates called as pathology nuggets. I think this is the 10th pathology nugget, and we'll be trying to do more and more cases so that it might be helpful for your final year exams, or it might help you in your real-time case diagnosis in your labs or in your hospital. Fine. And we have started something unique for postgraduate education pathology. It's I think the first in the country, and we are focusing system-wise, and all of them will be hosted on the Unacademy app as in the form of special classes, and all these special classes are free of cost, and any one of you can enroll to it. You can use the code PATHOCUPS if it asks for, and we are trying to incorporate your FRC path or your NEET super specialty polls in the form of MCQs as well. Hopefully we'll make more things together. Fine. So without any delay, we will go on to the case of today, the pathology nuggets 10. It's a bit of an interesting case. Let's see. I will end up with whatever we want to discuss, but first I want the histopathological diagnosis, your opinion on this case. Fine. It's a 10-year-old kid with a lung mass. I'm not going to give an exact information here, just a lung mass. Fine. This was the biopsy here. See here, what I'm going to describe, that I think there are 4 or 5 slides here. I'm going to describe each of them, and I would want you to comment on whatever you think while watching the video, and definitely at the end of the video I'll give you the diagnosis as well. Fine. So here what I'm seeing here is one appearance is here, the stoma is here. Obviously there are some empty spaces. I'm not going to comment on the empty space. I do have a vessel here. I cannot see the alveoli per se, right? What you can see is lots of cells here which are kind of spindled, and some places they are round blue cells, right? I'm not exactly sure of what it is, and let's go through it. And if you can notice this, I think you can guess the organ where it is involved. You can see the lining here, right? The lining is a flat lining. If you can see, this is actually the mesothelial lining, right? I can see the mesothelial lining here, so it should be not a lung mass to be specific. It should have been a pleural mass, right? So now my diagnosis almost is straightforward, but still we'll go ahead and look at the other images. Okay. Here again, you can see the perfect mesothelial lining on the top here, right? And below that I have lots of condensed here. It is not more spindly, it's more of a small round blue cells here, right? So a 10-year-old kid with a small round blue cell lesion in the pleural space or in the pleural lesion. I have few differential diagnoses in the mind. I hope you must have also had some DDs in your mind. Just do comment on them. The first thing for me, could it be an hematolymphoid lesion? Because ALL can happen, and ALL can go anywhere. It can also have a lung deposit. Who says? Who knows? It may have, right? So let's go ahead and see more things. Again, when you see here the same image, you can see the mesothelial lining again here, right? You can see the lining here. I'm having more of the small round blue cells, but one thing which I'm primarily going away from lymphoma or the leukemia ALL is the spindly nature, right? Somewhere it goes up, it becomes elongated. When I'm going to take off in lymphoma, it is more classical. It's characteristic finding, but still, one of the differential diagnoses is small round blue cell tumor. There are lots of tumors. One amongst them could still be lymphoma. Fine. Go to the next image. What I see here is the same as my first image. I have lots of collagen, must be the normal stoma of the pleura. The lining which has been broken here, and it's almost the same image here as well. I do see the spindle architecture in the lower half of this field. So I'm having a small round blue lesions in the pleural space, right? So I have many differential diagnoses in my mind. It could be a lymphoma, it could be a pleuropulmonary blastoma, it could be an embryonal rhabdomyosarcoma, right? There are lots of small cell tumor which can happen, right? So we did do the workup here. Unfortunately I don't have the IHC here, and it turned out to be a pleuropulmonary blastoma. Fine. It is a bit of an aggressive neoplasm. It's a blastemal tumor which happens predominantly in kids. Fine. It can have some places rhabdomyoblastic morphology also, so that should be focal. If it is entirely rhabdomyoblast kind, I want you to rethink of the primary diagnosis of pleuropulmonary blastoma. It could be an embryonal rhabdomyosarcoma, right? So the rhabdoid morphology should be focal. It should not be diffuse. Okay. So there are a few markers which are going to help me. Before that, there are a few types of pleuropulmonary blastoma. We'll just go and have a quick look about the tumor per se, the types of them, and then the differential diagnosis amongst them. Fine. It's a rare primitive neoplasm seen in the young children. So the child 10-year-old is one of the clues for me to say, okay, it could be in pleuropulmonary blastoma. Fine. It might be associated with cystic lesions in the lung. There are lots of deformities in the lung. can be part of them arising along with them, because see, when I'm having a cystic malformation of the lung, That's also a problem in the embryogenesis. Almost every blastemal tumors has some disorganized embryogenesis. That's why I'm having a blastemal morphology. So it might be associated with them. If it's associated with them, they might arise in the pulmonary parenchyma also, or in the mediastinum. Otherwise, it's generally a pleural lesion. The combination of pleuropulmonary blastema happens because with cystic lung malformations, it could be a part of the lung parenchyma as well. So if you have any cystic lung malformations excised and you're going to examine the tissue, I want you to take bits from the solid area because there could be a pleuropulmonary blastoma hidden amongst them. I don't want you to miss that, fine? There are 3 types of pleuropulmonary blastoma. It said that type 1 is a peripherally located, multicystic and thin wall structure, pleuropulmonary blastoma. Type 2 is both mixed solid and cystic architecture and have variable size nodules. Right? I'm just saying type 1 to 3, the solid nature becomes more and the cystic nature becomes less. Fine. This type 3, it's a tumor per se. It's a well circumscribed tumor. Mucoid appearance is not always the finding here. I'll have a solid mark attached to the pleura, or it can involve the lung parenchyma as well. Fine. You might see necrosis and hemorrhage. Again, reiterating the fact it could be a very, very aggressive lesion. I have to pick them up. All these 3 different types might have few pointers in my microscopy. Actually, the type 3 is close differential diagnosis for many of the tumors. We'll look at the differential diagnosis soon. Okay. Type 1, I said, the same thing, a thin wall structure. Maybe our case was kind of a thin wall lesion because I was seeing the lining epithelium. Just below the lining epithelium, we are seeing the tumor cells. I didn't have much of a solid area. If you can see, most of the images had empty space on the top, which means they are just cyst lining, right? Type 2, as the same said, I'm going to have both of the solid and cystic area. Type 3 will be a heterogeneous tumor. Fine, I can have more than one primitive elements. I can have blastemal small round cells like what we saw, a very hyperchromatic cell and a high NC ratio like any other blastemal tumor. I'm sure I must have seen at least one of the blastemal tumor. If not blastemal, you must have seen at least E-wings. So something of that sort, a very, very primitive cells I can have. Spindle areas can also be there, right? Though it is mentioned in type 3, again I don't have the history of small biopsy, so I am not sure whether it's from a solid lesion or not, right? The spindle morphology, what we saw here, is again characteristic of a type 3 pleuropulmonary blastoma. So it might be totally immature, or it can show some degree of maturity towards some lineage. I can have an immature chondroid elements as well. So again, one more differential diagnosis could be a mesenchymal chondrosarcoma, because that also will have a small round blue cell morphology plus a chondroid differentiation. Again, you should be very, very careful to differentiate these 2 lesions, right? Isolated clusters of anaplastic cells, pleomorphism and eosinophilic hyaline bodies can also be there. As I said that in the last slide itself, we saw that these are highly aggressive tumors with necrosis and hemorrhage. So I can definitely see pleomorphic areas for sure, fine? So if it is an FNAC or an fluid cytology, it's both dispersed as well as cohesive aggregates. What we generally look for in a pleural fluid cytology is when it's dispersed, I think of a lesion, I think of a malignant lesion generally. Here can have cohesive appearance as well. In a histomorphology, it's a bit difficult to say or differentiate between a lymphoma and a pleuropulmonary blastoma, unless and until you have an amazing way to do an immunocytochemistry, where yes, I can easily try to differentiate between these 2. Okay. When it comes to differential diagnosis, my IHC is going to play a main part. In a pleuropulmonary blastoma, most of them are vimentin positive. They are diffuse vimentin positivity all over the tumor. CD117 can be focally positive. That's one more marker. Again, it's focal positivity. It's not the diffuse positivity which is going to give me a clue. If it is rhabdomyoblastic differentiation, the rhabdomyoblastic markers might be positive, right? I want you to remember, again, it should be focal. The only one which can be diffuse is my vimentin. And if there are any epithelial components, they can be cytokeratin positive. EMA should be negative in this tumor, fine? Okay, so when you come to the differential diagnosis, I want you to consider few lesions. The first one is a pure embryonal rhabdomyosarcoma, definitely positive. Any PNETs which can come in the lung and the pleural region, you have to think about them, fine? It could be a very aggressive primitive tumor as well. It could be a teratoma, malignant combinative teratoma. It could be like that, because since this has areas of hemorrhage and pleomorphism, I won't think of a benign combinative teratoma here, right? I want you to think about any other, if it's a type 1 lesion, it could be a bronchogenic cyst, which could be a very close differential diagnosis, right? All of them should be considered. It's more of an histological diagnosis where little bit of vimentin and my CD117 plus or minus, again since it's focal, cytokeratin will be positive as I said in the pleuropulmonary blastoma and the epithelial component alone, fine? EMA should be generally negative. And as I said, myogenin will be negative in the blastemal cells. If something is rhabdomyoblastic morphology, please mark the areas and look for them in myogenin, they'll be positive. Again, a very focal rhabdomyoblastic morphology and an entirely primitive lesion still goes with pleuropulmonary blastoma with a rhabdoid differentiation maybe. It's not an embryonal rhabdomyosarcoma, because in embryonal RMS, every tumor cell should be positive for my myogen or your myoid A1. Fine. Okay. We saw a small, quick look about the pleuropulmonary blastoma and the different types. Fine. And again, to end with, there are lots of cases present for you in the Unacademy app. I want you to just enroll to the app, and they'll be under my profile. All of them will be the special classes. Please go through the special classes. We have covered endometrium and cervix. Hopefully in this month we'll be covering ovary as well. So if FGD is over, we'll have a consolidated idea of, and I want your inputs as well to make our education better. Because as you must have known that pathology is not simple. It's very, very exhaustive. The only way to learn more and become better is by communication. We'll communicate with each other. You present your cases as well. I'll present whatever case I see, and it will make sure we will reach different heights. Fine. Thank you for your time. And as I said that all of them are special classes. It will be available free of course. Fine. See you soon. Till then, bye bye from Dr. Ranjith. Bye bye.